Okay, so we're going to continue with electrocardiography, and today we're going to look at the conduction system. As we alluded to before, the heart is a muscular pump, but in order for the heart to pump, it needs to get electrical signals. Okay, it has to have the electrical signal, and the electrical signal starts in the SA node, the sinoatrial node, and the sinoatrial node is at the junction of the superior vena cava and the right atrium. Okay, the sinoatrial node is at the junction of the superior vena cava and the right atrium. It's located right there. This is the power station of the heart. Okay, the electrical impulse is generated here and it travels down through the atrium. Okay, it travels down through the atrium and it is retarded. That means it slows in the AV node. So it slows somewhat in the AV node. From the AV node, you have what we call the bundle of His. So the bundle of His is right here. And then the bundle of His splits. It splits and we get a left bundle going to the left and a right bundle going to the right. Okay? So the bundle, we call these the bundle branches. So this would be the left bundle branch, and this would be the right bundle branch. The bundle branches gives rise to what we call Purkinje fibers, which goes into the muscle. So these electrical wiring, so to speak, goes into the muscle. So it's further branching of the bundle branches. Okay, and we call them the Purkinje fibers. So you see the bundle branch come down and then it branches out to go into the muscle. So the electrical system of the heart is very important because that is how the heart pumps. If there is no electrical signal, the heart is going to stand still. Okay, so you have to know the electrical wiring of the heart, so to speak. So again, the SA node is located at the junction of the superior vena cava with the right atrium, and then the electrical impulse is generated in the SA node. It travels through the atrium, and when it comes down the atrium, there are some specialized fibers that is located in the atrium that allows easy transit of the electrical impulse, and it also moves from the right to the left. Okay, but the important thing is that the electric, this is what we call a subsidiary power station. A subsidiary power station, it is located right at the close to the AV junction, the atrioventricular junction, and this is the AV node. That's why it's called the AV node. Then the AV node gives rise to the bundle of His, and the bundle of His splits and give you a left bundle and a right bundle. The left bundle actually splits into two as well. So the left bundle splits into a left anterior fascicle and a left posterior fascicle. Okay, so this left bundle right here, if you were to look at it, it splits and it gives you a left anterior fascicle. So this is the left bundle now, which is splitting, and it gives you a left posterior fascicle. Okay, so the left bundle, which is right there, okay, the left bundle. So this is our left bundle. And if you guys look at our EKG thing, we usually depict it as left L, B, okay. So this left bundle branch block. Okay, sorry, we don't use this. We're not going to do block. So just left bundle branch. It's commonly blocked, so we commonly talk about left bundle branch block. So this is our left bundle branch. And this left bundle branch divides into a left anterior fascicle. So left anterior fascicle. Okay, so it gives us a left anterior fascicle and also a left posterior fascicle. So the left bundle divides to a left posterior fascicle. So it's just saying that it splits. Okay, so your left bundle splits, and the right bundle basically means this. It remains the same. So when the electrical impulse travels from the SA node through the atrium and it gets to the AV node, it slows. The electrical impulse slows. Then it travels down the bundle of His, and first it travels through the left bundle, and then from the left bundle it goes to the right bundle. That is the normal transit of the electrical impulse. Right away, you can see that the electrical impulse is traveling in a slanted direction. It is traveling from the atrium downwards like that. That's how the electrical impulse travels. So it's important to take note of that, okay? All right. All right. So as we mentioned before, the SA node, which is also known as the sinoatrial node, the electrical impulse originates in the SA node, and that's called the pacemaker of the heart. So the SA node is called the pacemaker of the heart because that is where the impulse starts. That's where the impulse originates. Electrical impulse then travels through the atria to the AV node where the impulse is delayed. It is slowed. It is slowed somewhat. Then it moves from the AV node down the bundle of His. So after the electrical impulse passes through the AV node, it travels to the bundle of His. Okay? And then the bundle of His will give rise to the bundle branches. The electrical impulse then travels to the left bundle branch first, and then to the right bundle branch. Again, the left bundle branch has two fascicles, a left anterior fascicle and a left posterior fascicle. And then it further divides, once it gets into the muscle, it further divides into what we call Purkinje fibers. So the bundle branches taper out to produce the Purkinje fibers, which are, these are specialized conduction tissues. So if you want to look at them as electrical wiring, okay, that would probably give you a much better visual of what's going on. So as mentioned before, remember what we said when we started out the ECG session. We said that depolarization of the atrium is going to give us the P waves. When we have depolarization of the ventricle, it's actually what's actually happening. You have stimulation of the His-Purkinje system, and you get the QRS because you have to have electrical impulse first before you get mechanical. So the electrical impulse is the QRS, and then the mechanical is when the heart contracts. All right. Now, as I pointed out before, the electrical impulse is going to travel from the right shoulder, so to speak, down to the apex of the heart. So it's going to have this trajectory. It's going to be slant. Okay, because of where the electrical generators and are located. So it's going to be somewhat like this. Okay, if you just think about it, the electrical impulse is going to be like this. The normal electrical impulse, however, is going to be like this. Now we're going to introduce the concept of the axis of the heart. And, you know, it might be a little tricky, but you have to go over it. And it's important to know the electrical axis of the heart because if you have disease of the heart, it can affect the electrical axis. You know, instead of the electrical impulse traveling down like this, it may travel up like that, or it may travel this way. So the electrical axis may vary depending on what disease state the heart is subjected to. Okay, so when we talk about the axis of the heart, it is the average direction of the electrical activity through ventricular activation. All right, and we say the electrical impulse starts in the SA node, it travels through the atrium, slows in the AV node, travels through the bundle of His, and then through the bundle branches, the left first and then the right. So it's very important for us to determine the axis of the heart because, as we pointed out before, if you have certain disease, it can affect the axis of the heart. Okay, the electrical axis. Um, okay, now you see we have this is a circular uh, configuration, and there are certain degrees assigned to it, and you're gonna have to know this. And whenever I teach this subject, I always tell the students you basically have to draw this, take a picture, whatever you need to do, walk around with it for at least, if you don't walk around with it for at least 6 months and look at it every day, you're not going to remember it. So this diagram is very important if you want to determine the axis of the heart. If you want to determine the axis of the heart, this diagram is extremely important. So your knowledge of what we did before on ECG is you're going to apply that to what I'm about to impart. So lead one, we usually, lead one is represented by a horizontal line, and lead one subtends an angle of 0 degrees. So it's horizontal, 0 degrees. Okay? Lead two subtends an angle of positive 60 degrees. So this is lead two right here, positive 60 degrees. Okay, so anything below the horizontal is positive, anything above the horizontal is negative. So lead two, so when you have your ECG and you have lead one, lead two, lead three, AVF, AVL, and AVF, all of these leads have different angles. So lead one subtends an angle of 0 degrees, is horizontal. Positive lead one is over here, 0 degree. And if you go to negative lead one, it's going to be on the opposite side. And it could be plus or minus 180. Lead two subtends an angle of positive 60. Positive lead two is right here. Remember, we say anything below the horizontal is positive, anything above the horizontal is negative. So this is positive lead two, which is 60 degrees. So if you go to the opposite side, still lead two, but it becomes now negative lead two. And negative lead two is minus 120. Okay? Minus 120. All right. Lead AVF, that's the next lead we come across. AVF, positive AVF is plus 90 degrees. Okay, so it's a vertical. Remember, we say anything below the horizontal is positive, anything above the horizontal is negative. So this is AVF. AVF is plus 90 degrees. Then we go to lead 3. Positive lead 3 is 120 degrees. 120 degrees. So if you have negative lead 3, it's going to be right over here, which is minus 60. Similarly, negative AVF is up here, and that's minus 90. Okay? AVL, so when you look at your ECG and you see AVL, AVL is minus 30. So again, so we're now above the horizontal. So anything above the horizontal is negative. So AVL, positive AVL is minus 30 degrees. Okay? And positive AVR is minus 150 degrees. Okay? So if AVL is positive, it's going to subtend an angle of minus 30 degrees. If AVL is negative, it's going to be down here, which is plus 150. AVR, positive AVR, and I'm going to, I'll further explain that. So get the concept. This is something you're going to have to sit down and go over. Okay, so don't get frustrated that, you're not going to probably get it right away, but you'll get it eventually. So positive AVR is minus 150. So if AVR was negative, it would be in the opposite direction, which is plus 30. So again, you have to draw this, and you're going to have to draw it by memory, and you're going to have to walk around with it for a good 6 months, look at it every day, and then you'll get it. All right. All right. So what we're doing now is just we're looking at the axis of the heart. The normal axis of the heart is between 0 degrees and 90 degrees. So this is what we mean. So remember, we said that the impulse is going to travel from up here and it's going to come straight down because the SA node is at the junction of the superior vena cava with the right atrium, which is about someplace over here. And the impulse is going to travel straight down because it's going to travel through the atrium, through the AV junction, and it's going to travel through the bundle branch. It's going to come down. So the normal axis is in this quadrant. The normal axis is in this quadrant. So it's from 0 to 90 degrees. Okay? The normal axis is in this quadrant. Normal axis is from 0 to 90 degrees. Okay? Again, normal axis is in this quadrant from 0 to 90 degrees. That is the normal axis. Okay? So when the impulse starts in the SA node and it's coming down, it should fall within this quadrant, 0 to 90 degrees. That's the normal axis. Now, as we pointed out before, in certain disease stating, you can get a right axis or a left axis, and we call that a right axis deviation or a left axis deviation. So when you have a right axis deviation, the electrical impulse is going to be in this quadrant. It's going to be on the right lower quadrant. So it's going to be from plus 90 to about plus 150. If the axis is plus 90 to plus 150, we call that right axis deviation. If the impulse is up in this quadrant now, say from 0 to minus 90, we call that left axis deviation. All right. So, and just by having axis deviation, that can tip us off if there's any disease going on, and the type of disease, as a matter of fact, that that the heart is subjected to. So again, the normal axis is between 0 and 90 degrees. Right axis is between 90, this is plus 90, and plus 150. The left axis is between 0 and minus 90. And to show you that again, okay, this is your circle, okay, and you need to know what is lead 1, what is lead 2, lead 3, lead AVF, AVL, AVR. Your normal axis is in this quadrant from 0 to plus 90. Right axis is plus 90 to plus 150. It's right inside here. It's on the right side, so it's right axis. And then in the left quadrant, left axis deviation, the electrical impulse is in this quadrant. So it's 0 to minus 90. So the axis of the heart can change if there's disease. If there's heart disease, the axis of the heart can change. Now, how do you determine the axis? How do you determine? You're looking at the ECG, and you guys should know how to determine the rate, okay, and the rhythm. Okay, we discussed the rate and rhythm before. All right, so to get the rate, 300 divided by the number of big blocks between the RR interval. Now we're going to talk about determining the axis. When you when you when you when you want to determine the axis of the heart, you have to look at the limb leads. And when we say look at the limb leads, you're going to look at lead 1, lead 2, lead 3, AVR, AVL, and AVF. So you're going to look at all the limb leads, and you're going to find the most isoelectric of them. When we say isoelectric, we talk about the positivity is almost equal to the negativity. That is what we call isoelectric. Anything was when you say something is iso, that means the same. Okay, so that means the upward deflection is almost the same as the downward deflection. After you find the lead with the most electricity, then you're going to find a lead that's perpendicular to that lead, and that will give you the axis of the heart. Relatively simple. But again, you have to know this. You have to know this, and that is why you have to draw it and you have to walk around with it. You have to use it, and then once you use it for 6 months to a year, you can toss it because you memorize it and you know. All right, so this is what we mean. So let's put it into action. This is a 12 lead ECG. So again, when you do your 12 lead ECG, you take 10 electrodes and you put it on the patient's skin, and you're going to get 12 leads. This is lead 1, this is lead 2, lead 3, AVR, AVL, and AVF. So these are your limb leads. The ones with the A in front of it is what we call the augmented limb leads. So AVR, AVL, and AVF are augmented limb leads. The A stand for augmented. And then, of course, these are your chest leads. We already discussed how you put the leads on, where V1 is located, V2, V3, V4, V5, and V6. We already discussed all of that. So, and we also discussed how you determine the heart rate. So the first thing when someone gets an EKG and you're going to read it, first you should look at the rhythm. So is it sinus rhythm or some other rhythm? When the rhythm is sinus, and when we say sinus, that means the impulse is generated from the SA node. When we say it's a sinus rhythm, we're saying that the rhythm is generated from the SA node. And that's what, that's what we have been saying all along. Sinus rhythm is generated from the SA node. If it's sinus rhythm, you're going to have P waves. So if you look in your ECG, this is your QRS, big QRS. Then after the QRS, you have your T wave. After the T wave, you have your P wave. If it's a sinus rhythm, you're going to have upright P waves in leads 2, lead 3, and AVF. And every P wave is going to be followed by a QRS. Okay? This is what we call a rhythm strip. Okay? We just take out lead 2 and we just let it run. You can see that there's a P wave, QRS, T wave, P wave, QRS, T wave, P wave, QRS, T wave, P wave, QRS, T wave. And it repeats itself because you have, when the impulse starts in the SA node, you're going to have atrial depolarization, atrial contraction is going to travel to the ventricle, ventricular depolarization, ventricular contraction. If the ventricle contracts, then it has to relax, and that's what the T wave represents. So upright P waves in leads 2, 3, and AVF makes it sinus rhythm, and the P wave is followed by a QRS. All right, so we established that this is sinus rhythm. All right, what is the rate? So the next thing is the rate. As we said before, you look at the number of big blocks between your RR interval. So just take one that falls on the RR interval. Sorry, take one that falls on the R wave, and let's use this. So this probably falls on the R wave. So this is 1, 2, 3. So it's roughly 3. So it's an approximation now. So you don't have to sit down and try to get an exact thing. So it's about 3 big blocks separating the RR interval. So the heart rate would be 300 divided by 3. So the heart rate is about 100 beats per minute. So 300 divided by 3 is 100. All right. Now we look at the rhythm and we say it's sinus rhythm because there are P waves, upright P waves in the inferior leads, which are leads 2, 3, AVF, and the P waves are followed by QRS. So it's a sinus rhythm. Now the axis. So these are the limb leads that we're talking about. These are the limb leads. When we say isoelectric, we mean the positive deflection. The positive deflection is on top and the negative deflection is below. Positive deflection is on top, the negative deflection is below. When we say isoelectric, we mean the lead that the positive deflection is almost equal to the negative deflection. That is what we mean when we say electricity or isoelectric. Okay, so if you look in your limb leads, the most isoelectric lead is lead 2. The positive deflection going up is almost equal to the negative deflection going down. It is not completely isoelectric, but it is the most isoelectric of your limb leads. Okay, lead 2. Then you find a lead that's perpendicular to lead 2. And you'll find out that it's going to be AVL. If you have your little cheat sheet with your cheat card, you'll see that AVL subtends angle of -30. So this patient has a left axis deviation. All right, let's go back to our, all right, so lead 1 is right here, lead 2 is there, AVL is there. So we said that the most isoelectric lead was lead 2. So lead 2 is right here. Perpendicular to lead 2 is AVL. So if you have your little cheat card, you can see that immediately. Okay? So perpendicular to lead 2 is AVL, and AVL subtends an angle of minus 30. So your axis is minus 30, so the patient has a left axis deviation. Okay? The most isoelectric lead is lead 2. Perpendicular to lead 2, using your cheat sheet, is AVL. Using your cheat sheet, AVL subtends an angle of minus 30. And you know that minus 30 is a left axis. Okay? All right, let's do another one. All right, so let's look at this. The first thing you're going to do is to determine, is this a sinus rhythm, yes or no? For a sinus rhythm, if you look in leads 2, lead 3, and AVF, you have to have an upright P wave. So this P wave is upright. And you have to have, your P wave has to be followed by QRS. So each P wave is going to be followed by QRS. So this is a sinus rhythm. Upright P waves in leads 2, 3, and AVF. Upright P waves in leads 2, 3, and AVF. Each P wave is followed by QRS. All right, so let's determine the rate. So it's difficult to see, but it's probably about 4 big blocks separating your RR interval. So the rate would be 300 divided by 4, which is about 75. So, you know, it's important to have proper gridding on your ECG, EKG paper so that you can do your rate and stuff like that. All right, so it is a sinus rhythm, rate about 75 beats per minute. Let's do the axis. To do the axis, you have to look in your limb leads. These are your regular limb leads, and these are your augmented limb leads. This is lead 1, this is lead 2, lead 3, AVR, AVL, and AVF. In your limb leads, which are the most isoelectric? The most isoelectric. The most isoelectric is AVL. That means the positivity is almost equal to the negativity. It is not completely isoelectric, but the most isoelectric is AVL. Perpendicular to AVL is lead 2. So we saw that before. We don't have to go back to the cheat sheet. All right, let's go back to the cheat sheet. So perpendicular to AVL is lead 2. Lead 2 subtends an angle of plus 60 degrees. So the axis would be plus 60. All right, so the axis is plus 60. We're not gonna go into any minutiae here. So if you say plus 60, you will get it correct. So remember, the normal axis is gonna fall between 0 and 90 degrees. So this is a normal axis. All right, let's look at another one. All right, so let's determine the rhythm. Upright P waves in leads 2, lead 3, and AVF. Each P wave is followed by a QRS. So this is sinus. This is sinus rhythm. Let's do the rate. You have 1, 2, 3, 4. There's 4 big blocks separating each RR interval. The heart rate is 300 divided by 4, which is about 75. Let's do the axis. Look in your limb leads. The most isoelectric in your limb lead is lead 1. The positivity is almost equal to the negativity. Okay? Which lead is perpendicular to lead 1? Because lead 1 is the most isoelectric. Let's go back. That is why you have to always have your cheat sheet So this is lead 1. Okay, lead 1 is right there. Perpendicular to lead 1 is AVF. Okay, when we say perpendicular, we mean 90 degrees. The angle is 90 degrees. So lead 1 is here. Perpendicular to lead 1 is AVF. So our most isoelectric is lead 1. Perpendicular to lead 1 is AVF. AVF subtends an angle of plus 90. AVF subtends an angle of plus 90. All right. So you have to have your cheat sheet. So plus AVF plus 90. AVF plus 90. So the axis is plus 90 degrees. All right. So it's, sort of borderline normal. Remember, the normal axis is between 0 and 90. But you look for the most isoelectric limb lead. Limb lead, not chest lead, limb lead. The most isoelectric limb lead, lead 1. Perpendicular to lead 1 is AVF. AVF subtends an angle of 90 degrees. So the axis is 90 degrees. Let's do this one. The rhythm, again, sinus, upright P waves in leads 2, 3, AVF. The P waves are upright. Each P wave is followed by a QRS, so it's sinus. What is the rate? Find the big blocks. How many big blocks separates the RR interval? It's about 1, 2, 3, 4. It doesn't have to be exact, but it's the closest thing. So it's about 4. So the heart rate is 300 divided by 4, which is 75. All right, so we get the rhythm, we have the rate, and now let's look at the axis. Just look in your limb leads. Limb leads. The most isoelectric in your limb leads, and when we say isoelectric, we mean the positive is almost equal to the negative. All right, so if we let's use lead 3. Let's use lead 3. So if lead 3 is the most isoelectric, perpendicular to lead 3, and that's where your cheat sheet comes in. That's why you have to walk there. So perpendicular to lead 3. So lead 3 is right here. This is lead 3. Okay? Perpendicular to lead 3 is AVR. So AVR subtends an angle, it's 90 degrees. Okay? So it's perpendicular. Lead 3 is right there. AVR is, so this positive AVR now. Positive AVR is minus 150. Positive AVR is minus 150. All right? So let's determine our axis. All right, so we say that the most isoelectric is lead 3. Perpendicular to lead 3 is AVR, but AVR is not positive. AVR is negative. Remember, it is positive AVR, which is minus 150. Positive AVR, which is because AVR is pointing downwards. AVR is a negative electric current. It's negative. It's below the baseline. So this is not positive AVR. This is negative AVR. All right, let's go back to our cheat sheet. All right, so positive AVR is minus 150 is over here. So if you want negative AVR, you have to come to the opposite side. Okay, so negative AVR is plus 30. So we have our cheat sheet, so we just go and we just plug it in. All right, so most isoelectric, lead 3. Perpendicular lead 3, AVR. AVR is negative, so we have to come down, so it's plus 30. So the axis is plus 30. If you were paying attention, you would realize that lead 3 is perpendicular to AVR, AVF is perpendicular to lead 1, and lead 2 is perpendicular to AVL. Okay, so it's, you know, it's like a X, all right? Lead 3 perpendicular to AVR, AVF perpendicular to lead 1, lead 2 perpendicular to AVL. Okay? All right, so we have another one. It's sinus because upright P waves are in leads 2, 3 AVF. P waves are followed by QRS. The rate is about 3 big blocks separating the RR interval. So the heart rate is 300 divided by 3, so it's about 100 beats per minute. Look in your limb leads, the most isoelectric. It's just it's probably lead 2. If you want to use lead 2, sorry, AVL. It's probably AVL. So AVL is probably the most isoelectric. Perpendicular to AVL is lead 2. Lead 2 subtends an angle of plus 60. You can work it out and get it even a little bit more accurate, but we're not going to do that today. If you give them an axis which is within 15 degrees, that's close enough. So the most isoelectric is AVL. Perpendicular to AVL is lead 2. Lead 2 subtends an angle of plus 60. So the axis is plus 60. Again, lead 3 perpendicular to AVR. AVF perpendicular to lead 1, lead 2 perpendicular to AVL. Okay? So that is how you determine the axis. Now, I cheated a little bit and I talk about sinus rhythm. But anyway, when we say sinus rhythm, we mean the impulse starts in the sinoatrial node. It starts in the SA node, and that is the normal. That's how the impulse normally originates in the SA node. So when we say sinus rhythm, we mean the impulse starts in the sinoatrial node. And again, the sinoatrial node is at the junction of the right atrium and the superior vena cava. When we say sinus rhythm, we talk about our normal sinus rhythm. The heart rate is between 60 and 100 beats per minute. When we say normal sinus rhythm, the heart rate is between 60 and 100 beats per minute. The P waves, they are usually followed by QRS in a 1-to-1 ratio. That means you have 1P and a QRS, 1P and a QRS, and it sort of repeats itself. The PR interval, remember we talk about PR interval? It is the duration from the beginning of the P wave to the beginning of the QRS. And that should be about 120 to 200 milliseconds. And the QRS complex, the duration that is from the beginning of the QRS to the end of the QRS should be less than 120. So if all of these criteria are satisfied, then we say it's sinus rhythm, our normal sinus rhythm. Okay, heart rate is between 60 and 100. Each P wave, upright P wave now. So the P wave has to be upright in leads 2, 3, and AVF. And after each P wave, you should have a QRS in a 1-to-1 ratio. The PR interval should be between 120 and 200 milliseconds, and the QRS complex, that is duration, should be less than 120. All right, so this is sinus rhythm. Upright P waves in leads 2, lead 3, and AVF. Each P wave is followed by a QRS, and if you look at the rate, so this rate 1, 2, 3, 4. So it's 4 big blocks. So the rate is 300 divided by 475. Okay, so it's sinus rhythm. It means that the impulse originates in the sinoatrial node. Okay, all right. When we say sinus bradycardia, when something is brady, it means slow. Sinus bradycardia means that the heart rate is less than 60 beats per minute. Sinus, the impulse is still coming from the SA node. So therefore, you're going to have upright P waves in leads 2, 3 AVF, and the P wave is going to be followed by QRS in a 1-to-1 ratio. Okay? Sinus bradycardia, the heart rate is less than 60 beats per minute. So let's look at this. Sinus, because you have upright P waves in leads 2, 3, AVF. Each P wave is followed by a QRS in a 1-to-1 ratio. And when you do the heart rate, let's use this. It's 1, 2, 3, 4, 5, 6. The heart rate here is 300 divided by 6, which is 50. Sinus bradycardia means the heart rate is less than 60. So this is heart rate of 50, so it's bradycardia. Sinus, because you have upright P waves in leads 2, 3, AVF, and each P wave is followed by the QRS. Sinus tachycardia. When something is tachy, it means fast. Tachy means fast. And when we say sinus tachycardia, it's a sinus rhythm with a heart rate greater than 100 beats per minute. The P wave, which is upright in leads 2, 3, and AVF, is followed by the QRS in a 1-to-1 ratio. This didn't project very well, but you can count it. You can see that there, well, first, if you look closely, you can see that there are P waves in leads 2, lead 3, and AVF. They're upright P waves. So it is sinus, and the number of big blocks separating the RR interval is about 2.5. 2.5. So if you divide 300 by 2.5, you're going to get a heart rate greater than 100 beats per minute. So this is sinus tachycardia. Sinus tachycardia, the heart rate is greater than 100 beats per minute, and sinus, the impulse is still coming from the sinoatrial node. So you're going to have P wave followed by QRS, P wave, QRS, and that ratio is going to remain the same. All right, so we're going to stop here. I think that's enough for you guys. Again,